Glucose spikes determine energy (CGMS). The conventional approach to blood sugar monitoring focuses on single-point measurements, fasting glucose or hemoglobin A1C, which provide an average over time but reveal nothing about the dynamic fluctuations that occur throughout each day. Two individuals with identical fasting glucose of 90 mg per deciliter and identical A1C of 5.4% can have radically different metabolic health, one maintaining stable glucose between 70 and 110 mg per deciliter, the other experiencing repeated spikes to 180 followed by crashes to 60. This variability, invisible to standard testing, drives energy fluctuations, inflammation, oxidative stress, and progressive metabolic dysfunction. Continuous glucose monitors, or CGMS, originally developed for diabetes management, have revealed that glucose volatility matters as much as absolute levels, and that non-diabetic individuals experience far greater glucose dysregulation than previously recognized. At its core, glucose variability creates metabolic stress through multiple mechanisms. When blood glucose spikes rapidly, particularly above 140 mg per deciliter in non-diabetics, the pancreas releases insulin in proportion to the elevation. This insulin surge drives glucose into cells, but often overshoots, creating reactive hyperglycemia 1 to 3 hours later. The spike itself generates reactive oxygen species through mitochondrial overload. When cells receive more glucose than they can immediately process, electron transport chains become saturated, producing free radicals that damage cellular components. Advanced glycation end products, or AGEs, form when excess glucose binds to proteins and lipids, creating inflammatory compounds that accumulate in tissues and contribute to aging. The postprandial glucose spike triggers inflammatory cytokine release, temporarily impairing endothelial function, the ability of blood vessels to dilate properly. Studies show that endothelial dysfunction persists for 2 to 4 hours after a glucose spike. Repeated spikes throughout the day create cumulative oxidative and inflammatory stress, even when average glucose remains in the normal range. Research published in JAMA analyzed CGM data from 57 non-diabetic individuals and found that 80% experienced glucose values exceeding 120 mg per deciliter, with some reaching 160. Despite normal fasting glucose and A1C, a landmark study published in Cell examined over 800 participants using CGMS, revealing massive individual variation in glycemic response to identical foods, with some individuals spiking from white bread while others remained stable, while the reverse occurred with bananas. Dr. Casey Means, co-founder of Levels Health and a Stanford-trained physician, emphasizes that glucose variability correlates with subjective energy crashes, brain fog, and afternoon fatigue. Research from the Weizmann Institute published in Cell Metabolism demonstrated that reducing glucose variability, even without changing average glucose, improved metabolic markers and reduced hunger. A study in diabetes care showed that glucose variability independently predicted cardiovascular events in non-diabetic individuals, beyond what fasting glucose or A1C revealed. The practical application of CGMs involves wearing a small sensor, typically on the upper arm or abdomen, that measures interstitial glucose every 1 to 15 minutes for 10 to 14 days. Systems like Freestyle Libre, Dexcom, and Nutrisens provide real-time data via smartphone. The goal for non-diabetics is maintaining glucose between 70 and 110 mg per deciliter at baseline, with post-meal peaks below 140 and minimal time below 70. CGM data reveals individual food responses, identifying which meals cause problematic spikes, and shows how exercise timing, sleep quality, and stress affect glucose. Walking for 10 to 15 minutes after meals consistently reduces glucose spikes by 20 to 30%. Combining carbohydrates with protein, fat, or fiber blunts absorption. Think of glucose like ocean waves, average sea level. Your A1C tells you little about whether you are experiencing calm waters or violent swells that damage the coastline with each crash. Using continuous glucose monitoring is a practical way to measure real-time metabolic responses to food, exercise, and stress, revealing glucose variability that standard testing misses and enabling precise interventions to reduce metabolic damage. Insulin resistance starts earlier than you think. The standard diagnostic criteria for metabolic dysfunction focus on late-stage markers. Fasting glucose above 100 mg per deciliter for prediabetes, above 125 for diabetes, or A1C above 5.7%, yet cellular insulin resistance begins years or even decades before these thresholds are crossed. By the time fasting glucose becomes elevated, the pancreas has been secreting 2 to 3 times normal insulin levels to maintain those seemingly normal glucose readings, a state called compensated insulin resistance or hyperinsulinemia. The problem is that standard medical screening measures glucose but rarely measures insulin, missing the early warning signal that predicts future diabetes, cardiovascular disease, Alzheimer's disease, and numerous cancers. Current estimates suggest that over 50% of American adults have some degree of insulin resistance, while only 15% meet criteria for prediabetes or diabetes based on glucose alone. At its core, insulin resistance is a state where cells, particularly in muscle, liver, and adipose tissue, respond less effectively to insulin's signal to absorb glucose from the bloodstream. Insulin binds to cell surface receptors, triggering a cascade that moves GLU, T.4 glucose transporters to the cell membrane. In insulin-resistant states, this signaling pathway becomes impaired through multiple mechanisms. Chronic nutrient overload, particularly of saturated fats and refined carbohydrates, leads to intracellular lipid accumulation, including diacylglycerols and ceramides, which interfere with insulin receptor substrate proteins. Mitochondrial dysfunction reduces the cell's capacity to process incoming nutrients, creating a backlog. Inflammation, driven by visceral adipose tissue and dysbiotic gut bacteria, releases cytokines that further impair insulin signaling. The pancreas compensates by producing more insulin, often doubling or tripling output, to achieve the same glucose disposal. This hyperinsulinemia successfully maintains normal glucose, masking the underlying dysfunction. But high insulin itself is pathological, promoting fat storage, inhibiting fat oxidation, increasing hunger, and accelerating cellular aging. Research published in the Lancet Diabetes Endocrinology demonstrated that insulin resistance, measured by HOMIL, or homeostatic model assessment of insulin resistance, begins rising in the 20s and 30s, long before glucose abnormalities appear. A study from the University of Virginia published in Diabetes Care showed that individuals with normal glucose but elevated fasting insulin, above 10 micro international units per milliliter, had a 3-fold increased risk of developing diabetes over 10 years. Robert Lustig at UC San Francisco has documented that 40% of normal weight individuals show metabolic dysfunction when insulin is measured, challenging the assumption that lean equals metabolically healthy. Research published in Cell Metabolism by Dr. Gerald Shulman at Yale demonstrated using magnetic resonance spectroscopy that insulin resistance appears in muscle and liver before any clinical markers change, detectable through intracellular lipid accumulation. A study in JAMA Internal Medicine found that postprandial insulin, measured 2 hours after a glucose load, predicted future diabetes better than fasting glucose. The practical approach requires testing beyond standard panels. Fasting insulin should be measured alongside fasting glucose to calculate HOMAIR. Using the formula fasting glucose times fasting insulin divided by 405, with values above 2 indicating insulin resistance, optimal fasting insulin is below 7 micro international units per milliliter, preferably below 5. The triglyceride to HDL ratio serves as a proxy when insulin testing is unavailable, with ratios above 2 suggesting insulin resistance. Early intervention focuses on reducing dietary factors that drive resistance, minimizing refined carbohydrates and seed oils high in omega-6 fatty acids, implementing time-restricted eating to reduce insulin secretion frequency, and prioritizing Zone 2 exercise, which improves insulin sensitivity through increased mitochondrial capacity and GLU T.4 expression. Resistance training enhances glucose disposal by increasing muscle mass, the primary glucose sink. Think of insulin resistance like hearing loss. The signal, insulin, stays the same, but cells require increasing volume, higher insulin levels, to receive the message. By the time you notice the problem, significant damage has occurred. Testing for and addressing insulin resistance early is a practical way to prevent progression to diabetes and associated metabolic diseases. Intervening during the compensated phase when dysfunction is still reversible through lifestyle modification. The order you eat matters. Food sequencing, the macronutrient composition of a meal, the grams of protein, carbohydrates, and fat, has dominated nutritional discussion for decades, yet emerging research reveals an overlooked variable that significantly impacts glycemic response: the sequence in which those macronutrients are consumed. Eating the same foods in a different order, vegetables first, then protein and fats, then starches and sugars, produces measurably lower glucose and insulin spikes compared to consuming carbohydrates first or eating all components simultaneously. This phenomenon, documented in individuals with diabetes, prediabetes, and normal glucose tolerance, suggests that meal architecture, not just meal composition, influences metabolic outcomes. The mechanism involves gastric emptying rates, nutrient absorption kinetics, and the physical properties of fiber, creating a practical intervention that requires no calorie restriction or food elimination. At its core, food sequencing affects glucose response through gastric emptying and intestinal absorption dynamics. When you consume non-starchy vegetables first, the fiber, particularly soluble fiber like pectin and beta-glucan, forms a viscous gel in the stomach and small intestine. This gel physically slows the transit of subsequently consumed food, delaying carbohydrate breakdown and glucose absorption. Protein and fat, consumed after vegetables but before starches, trigger the release of incretin hormones including GLP-1 and GIP, which slow gastric emptying further and stimulate insulin secretion in a glucose-dependent manner. By the time high glycemic carbohydrates enter the digestive system, the gut environment has been modified to slow their absorption, creating a more gradual glucose rise. When carbohydrates are consumed first on an empty stomach, they encounter no physical barrier, digest rapidly, and flood the bloodstream with glucose. The same meal, identical in composition, produces a 20% lower glucose spike when consumed in the vegetables, protein-carbohydrate sequence. A landmark study published in Diabetes Care by Dr. Lewis Aron at Weill Cornell Medicine examined individuals with type 2 diabetes consuming identical meals in different sequences. When participants ate vegetables and protein before carbohydrates, glucose levels at 30 and 60 minutes post-meal were significantly lower, with reductions of approximately 30 to 40 milligrams per deciliter, compared to carbohydrate-first consumption. A follow-up study published in BMJ Open Diabetes Research and Care confirmed these findings in prediabetic individuals, showing that food order reduced post-meal glucose and insulin. Research from Jesse Inchauspé, biochemist and author of Glucose Revolution, using continuous glucose monitors in non-diabetic individuals, demonstrated that a savory breakfast consumed before a sweet breakfast component, such as eggs before toast, reduced glucose spikes by 35%. A study in clinical nutrition showed that consuming a vegetable salad 15 minutes before a carbohydrate-rich meal reduced postprandial glucose by 20%. The practical protocol is straightforward. Begin meals with non-starchy vegetables, ideally raw or lightly cooked to preserve fiber structure, such as a salad, cruciferous vegetables, or leafy greens, consuming at least 1 to 2 cups. Wait 5 to 10 minutes if possible, or at minimum eat vegetables first before moving to other components. Next, consume protein and healthy fats, including fish, poultry, eggs, nuts, or avocado. Finally, eat starches and any dessert or sweet components. If meal structure doesn't allow strict sequencing, simply ensuring vegetables are consumed before or at the beginning of the meal, rather than as a side eaten simultaneously with starches, provides benefit. Think of fiber as a speed bump in your digestive tract. Installing it before the carbohydrates arrive slows their absorption, preventing the metabolic collision of rapid glucose influx. Implementing food sequencing is a practical way to reduce postprandial glucose and insulin spikes without changing food choices, leveraging the physical and hormonal effects of fiber and protein to modulate carbohydrate absorption kinetics. The dawn phenomenon. Why morning glucose spikes? Many individuals using continuous glucose monitors discover a puzzling pattern, waking with blood glucose 10 to 30 milligrams per deciliter higher than when they fell asleep. Despite 8 hours of fasting, this elevation, occurring before any food consumption, seems to violate basic metabolic logic, yet it affects an estimated 50% of individuals with type 2 diabetes and a significant portion of non-diabetics, particularly those with any degree of insulin resistance. The dawn phenomenon, as it is clinically termed, results from the body's hormonal preparation for waking, a coordinated release of counter-regulatory hormones that mobilize glucose stores to fuel the anticipated demands of consciousness. While this response is physiologically normal, excessive morning glucose elevation indicates metabolic inflexibility and predicts deteriorating glucose control throughout the day. At its core, the dawn phenomenon is driven by the circadian, regulated release of counter-regulatory hormones in the early morning hours, typically between 4 and 8 a.m. Cortisol, following its diurnal rhythm, rises sharply in the hour before waking, a pattern called the cortisol awakening response. Cortisol stimulates hepatic gluconeogenesis, the production of new glucose from amino acids and glycerol, and promotes glycogenolysis, the breakdown of stored glycogen, growth hormone, which peaks during deep sleep. Also promotes glucose production and reduces glucose uptake by peripheral tissues in metabolically healthy individuals. The pancreas releases a small amount of insulin to counteract this glucose rise, maintaining stable blood sugar. In insulin-resistant individuals, particularly those with compromised beta cell function, insulin response is insufficient, allowing glucose to climb. The magnitude of the dawn phenomenon correlates with the degree of insulin resistance and hepatic glucose overproduction. Interestingly, the Somogyi effect, a different phenomenon, involves nocturnal hypoglycemia triggering excessive counter-regulatory hormone release, causing morning hypoglycemia, distinguishable from true dawn phenomenon by checking glucose at 3 a.m. Research published in Diabetes Care examined the dawn phenomenon in type 2 diabetics using CGMs, finding an average glucose rise of 30 to 50 milligrams per deciliter between 6 and 9 a.m. A study published in the Journal of Clinical Endocrinology and Metabolism demonstrated that the magnitude of morning glucose elevation correlated with elevated evening cortisol, suggesting HPA axis dysregulation. Dr. Eel Hirsch at the University of Washington has documented that the dawn phenomenon contributes significantly to elevated A1C, particularly in individuals who achieve good daytime glucose control. Research from the University of Chicago published in Diabetologia showed that even non-diabetic individuals with metabolic syndrome exhibit exaggerated dawn glucose rises, averaging 15 to 20 milligrams per deciliter. A study in Metabolism found that high-protein, low-carbohydrate dinners reduce the dawn phenomenon compared to high-carbohydrate evening meals. The practical interventions target both the cortisol response and hepatic glucose production. Consuming a small amount of protein and fat before bed, such as 1 to 2 tablespoons of almond butter or a handful of nuts, provides sustained fuel that reduces nocturnal counter-regulatory hormone secretion. Morning exercise, even a 15-minute walk immediately upon waking, enhances insulin sensitivity and glucose uptake, blunting the rise. Apple cider vinegar, 1 to 2 tablespoons in water before bed, has been shown in small studies to reduce morning glucose, possibly through effects on hepatic glucose production. Stress management practices that reduce evening cortisol, including meditation or journaling before bed, may moderate the cortisol awakening response. Avoiding late-night eating, finishing dinner 3 hours before sleep, prevents insulin spikes that can cause reactive hypoglycemia and subsequent counter-regulatory hormone release. Think of the dawn phenomenon as an overzealous alarm system, preparing for a threat. Waking that doesn't require such aggressive glucose mobilization in modern sedentary life. Managing the dawn phenomenon is a practical way to reduce morning hypoglycemia, improve overall glycemic control, and address the hormonal and metabolic factors that drive excessive hepatic glucose production during sleep-wake transition. Alcohol crashes blood sugar hours later. Alcohol consumption produces immediate effects that most drinkers recognize: lowered inhibitions, impaired coordination, and altered cognition. But the metabolic consequences extend far beyond the period of intoxication, creating a biphasic glucose response that few people anticipate. In the hours immediately following alcohol consumption, particularly of mixed drinks containing sugar, blood glucose often rises, driven by the carbohydrate content and alcohol's effects on hormonal regulation. However, 4 to 12 hours post-consumption, frequently in the middle of the night or early morning, blood glucose can drop precipitously, sometimes into hypoglycemic ranges below 70 milligrams per deciliter. This delayed crash triggers awakening, anxiety, night sweats, and the release of stress hormones, fragmenting sleep architecture and creating a cascade of metabolic disruption that persists into the following day. At its core, alcohol-induced hypoglycemia results from the liver's prioritization of alcohol metabolism over glucose homeostasis. When you consume alcohol, It is absorbed rapidly and metabolized primarily in the liver by alcohol dehydrogenase, converting ethanol to acetaldehyde, then by aldehyde dehydrogenase to acetate. This process consumes NAD+, the coenzyme required for gluconeogenesis, the production of new glucose from non-carbohydrate sources. With NAD+ depleted, the liver cannot effectively produce glucose, creating dependence on existing glycogen stores. If those stores are depleted, common after evening exercise or extended time since eating, blood glucose falls. Alcohol also stimulates insulin secretion initially, particularly when consumed with carbohydrates, driving glucose into cells. The combination of impaired glucose production and enhanced glucose disposal creates conditions for hypoglycemia hours later when insulin remains elevated but hepatic glucose output is suppressed. The body responds to falling glucose by releasing cortisol, adrenaline, and noradrenaline, stress hormones that mobilize any remaining glucose and trigger awakening. Research published in Alcohol and Alcoholism demonstrated that even moderate alcohol consumption, 2 to 3 drinks, suppressed hepatic gluconeogenesis for 6 to 12 hours. A study in the American Journal of Medicine examined individuals with type 2 diabetes consuming alcohol with dinner, finding significantly increased risk of nocturnal and morning hypoglycemia, particularly when combined with glucose-lowering medications. Dr. David Kerr, a diabetes researcher, documented using CGMs that alcohol consumption in the evening produced glucose drops averaging 30 to 50 milligrams per deciliter in the early morning hours. Research published in Diabetes Care showed that alcohol consumed without adequate carbohydrate food pairing increased hypoglycemia risk threefold. A study in sleep found that alcohol-induced nocturnal hypoglycemia fragmented sleep architecture, reducing REM, sleep and deep sleep even beyond alcohol's direct sedative effects, which already suppress REM sleep. The practical approach focuses on minimizing hypoglycemia risk through strategic consumption patterns. Avoid drinking on an empty stomach or after intense exercise when glycogen stores are depleted. Pair alcohol with protein and complex carbohydrates, which provide sustained glucose availability. Limit consumption to 1 to 2 drinks, as risk increases dose dependently. Avoid late-night drinking, as this positions the metabolic nadir during sleep when you cannot consciously respond to hypoglycemia symptoms. If consuming alcohol, consider eating a small protein and fat snack before bed to provide gluconeogenic substrates. Monitor morning glucose if using a CGM, as persistent morning lows indicate the previous evening's alcohol affected hepatic glucose production. Individuals taking diabetes medications, particularly insulin or sulfonylureas, face significantly elevated risk and should consult physicians about alcohol consumption. Think of alcohol metabolism as commandeering the liver's production facility. While it processes this toxin, normal operations, including glucose production, shut down, leaving you metabolically vulnerable hours later. Understanding alcohol's delayed effect on blood glucose is a practical way to minimize metabolic disruption, sleep fragmentation, and hypoglycemia risk by strategically timing consumption and pairing alcohol with appropriate foods. The breathing you're doing wrong. Mouth breathing reshapes your face. Most people assume that breathing through the mouth versus the nose is a trivial preference with no lasting consequences. Yet chronic mouth breathing, particularly during childhood development, permanently alters craniofacial structure, creating a cascade of changes that affect not only facial aesthetics but also airway function, sleep quality, and long-term health. The human skull is not a fixed structure but a dynamic system that responds to functional pressures, particularly during the critical growth periods of childhood and adolescence. When nasal breathing is compromised, whether by anatomical obstruction, chronic congestion, or habit, the shift to mouth breathing changes tongue position, alters muscle activation patterns, and modifies the directional forces acting on developing bone. The result, documented in orthodontic and anthropological research, is a characteristic facial morphology: elongated face, recessed chin, narrow dental arches, an increased risk of obstructive sleep apnea, conditions that were rare in pre-industrial populations who maintain nasal breathing. At its core, craniofacial development is guided by Wolff's law, the principle that bone adapts to the mechanical stresses placed upon it. During nasal breathing, the tongue rests against the palate, the roof of the mouth, creating continuous upward and outward pressure that stimulates lateral growth of the maxilla, the upper jaw. This pressure, exerted thousands of times daily, widens the palate and promotes forward facial development. When chronic mouth breathing occurs, the tongue drops to the floor of the mouth to allow airflow, removing this critical growth stimulus. Without the tongue's scaffolding pressure, the maxilla grows narrower and longer rather than wider and forward, creating a high-arched, V-shaped palate instead of a broad, U-shaped arch. The mandible, or lower jaw, follows the maxilla's positioning, and without proper forward development, recedes backward, reducing airway space behind the tongue. The face elongates vertically as the body attempts to create airway space through downward and backward growth, a pattern called long face syndrome or adenoid facies. Studies comparing identical twins where one developed chronic mouth breathing show measurable facial divergence. Research published in the Angle Orthodontist examined children over 6 years, comparing habitual mouth breathers to nasal breathers. The mouth breathing group developed significantly longer lower facial height, narrower maxillary width, and increased mandibular plane angle, indicating downward and backward growth. A study published in General Dentistry analyzed pre-industrial skulls from museum collections, finding broad dental arches, well-developed facial structures, and minimal malocclusion, contrasting sharply with modern populations where 30 to 45% require orthodontic intervention. Dr. John Mew, the orthotropist who developed the concept of orthotropics, documented hundreds of cases where correcting mouth breathing and tongue posture during growth years improved facial development. Research from Stanford published in the Laryngoscope showed that children with adenoid hypertrophy, a common cause of mouth breathing, who underwent adenoidectomy before age 5 showed more normal facial development than those treated later. A study in American Journal of Orthodontics found that mouth breathing correlated with posterior crossbeat, where upper teeth sit inside lower teeth. In 68% of cases, the practical interventions depend on age and cause. In children, addressing anatomical obstructions, enlarged adenoids or tonsils, chronic allergies, or structural issues is critical before age 10 when most facial growth occurs. Myofunctional therapy, exercises that retrain tongue posture and breathing patterns, can establish nasal breathing habits. The proper resting tongue position places the entire tongue, including the posterior third, against the palate, with lips closed and teeth slightly apart. In adults, facial structure is largely set, but establishing nasal breathing still improves sleep quality, reduces snoring, and may prevent further deterioration. Addressing chronic nasal congestion through saline rinses, identifying food sensitivities, or treating environmental allergies restores nasal patency. Orthodontic expansion, either traditional or surgical, can widen narrow palates even in adults, though results are more limited than childhood intervention. Think of the tongue as an internal orthodontic appliance, working 24 hours daily to shape the skull. When positioned correctly, it builds wide airways and balanced faces. When dropped and inactive, it allows collapse and constriction, establishing and maintaining nasal breathing, particularly during developmental years, is a practical way to support proper craniofacial growth, optimize airway anatomy, and prevent structural patterns that compromise breathing, sleep, and facial aesthetics. Mouth taping sounds insane. The suggestion to tape your mouth shut during sleep sounds like pseudoscience or a dangerous intervention that could compromise breathing. Yet this practice, supported by emerging research and clinical experience, has gained traction in sleep optimization and performance communities. The premise challenges the assumption that the body will naturally choose the optimal breathing route during sleep, revealing instead that many individuals default to mouth breathing at night, even if they breathe nasally during waking hours. This nocturnal mouth breathing, often unrecognized, dries oral tissues, disrupts sleep architecture, increases snoring and sleep apnea severity, and creates morning symptoms including dry mouth, sore throat, and brain fog. Mouth taping, using specialized tape or gentle medical tape to keep lips closed, forces nasal breathing, which filters, humidifies, and warms air, increases nitric oxide delivery, and promotes deeper, more restorative sleep. At its core, the shift to mouth breathing during sleep occurs due to multiple factors, including tongue position changes with muscle relaxation, nasal congestion that worsens in supine positions, and habitual patterns established during waking hours. When you breathe through your mouth during sleep, you bypass the nasal passages, which perform critical functions. The nasal turbinates filter particles, bacteria, and allergens, while nasal mucosa humidifies air to 95% saturation and warms it to body temperature, protecting lower airways from irritation. The nose produces nitric oxide, or NO, a molecule with bronchodilatory, antimicrobial, and vasodilatory properties. Nasal breathing delivers this NO to the lungs, improving oxygen transfer and blood flow. Mouth breathing bypasses all these functions, delivering cold, dry, unfiltered air that irritates airways and reduces oxygenation efficiency. Additionally, mouth breathing during sleep often correlates with tongue position that partially obstructs the airway, worsening or even causing obstructive sleep apnea events. Studies using polysomnography show that forcing nasal breathing through mouth taping reduces apnea, hypopnea index, or AHI, the number of breathing disruptions per hour, in individuals with mild to moderate sleep apnea. Research published in the Journal of Oral Rehabilitation examined mouth taping in individuals with mild obstructive sleep apnea, finding significant reduction in snoring intensity and frequency. A study published in Frontiers in Psychology documented that mouth breathing during sleep increased sympathetic nervous system activity, reducing heart rate variability and impairing recovery, while nasal breathing maintained parasympathetic dominance. Dr. Mark Burhen, a dentist and sleep researcher, has documented thousands of patient reports showing improved sleep quality, reduced morning dry mouth, and decreased need for water overnight with mouth taping. Research from the University of Otago in New Zealand, published in Respiratory Physiology and Neurobiology, showed that nasal breathing increased oxygen saturation and reduced respiratory rate compared to mouth breathing during sleep. A study in sleep and breathing found that mouth breathing during sleep correlated with higher inflammatory markers and oxidative stress. Patrick McKeown, breathing educator and author of The Oxygen Advantage, emphasizes that mouth taping should only be attempted after confirming the ability to breathe comfortably through the nose while awake. The practical implementation requires proper preparation and safety considerations. First, confirm that you can breathe easily through your nose while awake. If nasal passages are chronically congested, address this before attempting mouth taping through saline rinses, nasal dilator strips, allergy management, or medical evaluation. Use specialized mouth tape designed for this purpose, such as Somnifix or Myotape, or gentle medical tape like 3M Micropore. Avoiding duct tape or strong adhesives, apply a small piece vertically over the lips, not covering the entire mouth, allowing the tape to be easily removed if needed. Start with daytime practice, taping during reading or watching television to acclimate. Some individuals prefer horizontal taping or X patterns for adjustable resistance. Contraindications include severe sleep apnea, active nasal infection, recent nasal surgery, or inability to breathe nasally. Mouth taping is not a substitute for CPAP. In diagnosed moderate to severe obstructive sleep apnea, think of mouth taping as training wheels, forcing the correct pattern until nasal breathing becomes automatic. Once habitual, many find they no longer need tape. Using mouth tape during sleep is a practical way to maintain nasal breathing throughout the night, improving oxygenation, reducing airway irritation, and promoting deeper sleep by preventing the unconscious shift to mouth breathing. CO2 tolerance predicts performance. The fitness world obsesses over oxygen uptake, oxygen delivery, and oxygen saturation, treating it as the limiting factor in performance and endurance. Yet carbon dioxide, typically viewed only as a waste product to be expelled, plays an equally critical role in respiration, cellular metabolism, and exercise capacity. Your tolerance to rising carbon dioxide levels, measured by how long you can comfortably hold your breath or maintain slow breathing rates, predicts your ability to remain calm under stress, sustain high-intensity effort, and utilize oxygen efficiently. Paradoxically, most people are chronically over-breathing, a pattern called hypercapnia, exhaling carbon dioxide faster than it is produced, which actually reduces oxygen delivery to tissues through the Bohr effect. Training CO2 tolerance through specific breathing protocols improves athletic performance, increases breath hold time, and enhances stress resilience. At its core, carbon dioxide functions as the primary respiratory stimulus. The urge to breathe is not triggered by low oxygen but by rising CO2 levels detected by chemoreceptors in the brainstem and carotid bodies. When CO2 accumulates during breath, holding or slow breathing, these receptors signal the respiratory center to increase ventilation, creating the sensation of air hunger. Individuals with low CO2 tolerance experience this urge at relatively low CO2 concentrations, limiting breath, hold duration and creating breathing patterns characterized by high respiratory rate and shallow breaths. CO2 also regulates the oxygen-hemoglobin dissociation curve through the Bohr effect. Higher CO2 and lower pH, more acidic conditions, cause hemoglobin to release oxygen more readily to tissues. When you chronically hyperventilate, exhaling too much CO2, blood pH becomes more alkaline. Hemoglobin holds oxygen more tightly, and less oxygen is delivered to muscles and organs despite normal oxygen saturation. This explains why anxious, rapid breathing can create feelings of lightheadedness. The blood is well oxygenated, but tissues are oxygen deprived. Research published in Respiratory Physiology and Neurobiology demonstrated that free divers with superior breath hold times, exceeding 4 minutes, showed significantly higher CO2 tolerance. Measured by time to first breathing urge during breath holds, a study in Frontiers in Physiology found that CO2 tolerance training, using breath hold exercises, improved cycling time trial performance by reducing perceived exertion at identical workloads. Dr. Peter Litchfield, a breathing behavior analyst, has documented that individuals with anxiety disorders typically show reduced CO2 tolerance and chronic hyperventilation patterns. Research from the University of Portsmouth published in European Journal of Applied Physiology showed that 4 weeks of breath hold training increased CO2 tolerance, measured by end tidal CO2, by 12% and improved repeated sprint performance. The control pause test, developed by Dr. Konstantin Buteyko, measures the time from the end of a normal exhale to the first definite urge to breathe, with scores below 20 seconds indicating low CO2 tolerance and scores above 40 seconds indicating excellent tolerance. The practical training protocols focus on gradual exposure to elevated CO2. The control pause test provides a baseline. Sit comfortably, breathe normally, exhale gently, and hold. Timing until you feel the first distinct urge to breathe, not maximum breath hold. Aim to increase this measurement through regular practice. CO2 tolerance tables involve repeated breath holds with decreasing recovery time. For example, holding breath for 60% of maximum for 5 rounds, with recovery periods decreasing from 2 minutes to 30 seconds. Box breathing with extended holds, such as 4-second inhale, 7-second hold, 8-second exhale, increases comfort with CO2 accumulation. Reduced breathing volume training, consciously breathing more slowly and shallowly than normal for 5 to 10 minutes, builds tolerance. Think of CO2 tolerance like heat adaptation. Initial discomfort is significant, but systematic exposure increases your threshold, allowing you to function effectively in previously intolerable conditions. Training carbon dioxide tolerance is a practical way to improve respiratory efficiency, enhance oxygen delivery through the Bohr effect, and increase performance capacity by raising the threshold at which air hunger triggers breathing rate increases. Humming increases nitric oxide 15-fold. Nitric oxide is one of the most important signaling molecules in human physiology, regulating blood pressure through vasodilation, supporting immune function through antimicrobial activity, and improving oxygen uptake in the lungs. Yet most people are unaware that a simple action, humming, can increase nasal nitric oxide production by 15-fold compared to silent breathing. This dramatic elevation, documented in peer-reviewed research, occurs because the paranasal sinuses, air-filled cavities surrounding the nasal passages, are primary production sites for nitric oxide, and the oscillating airflow created by humming enhances gas exchange between the sinuses and nasal cavity. The practice, which appears in traditional pranayama techniques like Brahmari breath or bee breath, offers a zero-cost intervention with immediate physiological effects measurable within seconds. At its core, nitric oxide is synthesized from L-arginine by nitric oxide synthase enzymes located in endothelial cells, neurons, and epithelial cells lining the paranasal sinuses. In the nasal passages, nitric oxide serves multiple functions. It dilates pulmonary blood vessels, improving ventilation perfusion matching, the alignment of airflow and blood flow in the lungs, enhancing oxygen absorption. Nitric oxide exhibits broad-spectrum antimicrobial properties, inactivating bacteria, viruses, and fungi, which is why nasal breathing provides superior protection against respiratory infections compared to mouth breathing. Systemically, nitric oxide derived from nasal breathing enters the lungs and bloodstream, where it promotes vasodilation, reducing blood pressure and improving circulation. The paranasal sinuses, particularly the maxillary sinuses, maintain high concentrations of nitric oxide, approximately 100 to 200 parts per billion, far exceeding nasal cavity levels. Humming creates acoustic vibrations that oscillate sinus air at a frequency that enhances diffusion from sinuses into nasal passages, increasing the concentration of nitric oxide in inhaled air. The foundational research was published in American Journal of Respiratory and Critical Care Medicine by Dr. John Lundberg at the Karolinska Institute, demonstrating that humming increased nasal nitric oxide levels 15-fold compared to quiet exhalation. A follow-up study published in Respiratory Research showed that this elevation persisted for several minutes after humming ceased. Research published in the Journal of Alternative and Complementary Medicine examined Bhramari pranayama, finding significant increases in nasal nitric oxide and improvements in parasympathetic tone measured by heart rate variability. A study in European Respiratory Journal demonstrated that sinus surgery patients who practiced humming post-operatively showed faster recovery and reduced infection rates, attributed to enhanced nitric oxide levels. Dr. Luis Ignaro, who won the Nobel Prize for his work on nitric oxide, has noted that nasal breathing, particularly with humming, provides therapeutic nitric oxide delivery without pharmaceutical intervention. The practical application is remarkably simple. Sit comfortably and breathe in through the nose. On the exhale, keep your mouth closed and produce a humming sound, any pitch, feeling the vibration in your nasal passages and face. The vibration itself, not the loudness, drives nitric oxide production. Practice for 5 to 10 breaths, or 1 to 2 minutes, particularly upon waking or before exercise. Some practitioners use humming during nasal breathing exercises, alternating normal breaths with humming exhales. The technique is particularly valuable during early stages of respiratory infections, when enhanced nitric oxide may provide antimicrobial benefits, or before aerobic exercise, when increased nitric oxide can improve oxygen uptake. Bhramari breath involves covering the ears with fingers while humming, intensifying the internal sound and promoting deeper relaxation. Think of your sinuses as nitric oxide reservoirs. Silent breathing draws only from the nasal cavity, but humming opens the valve to flood airways with concentrated nitric oxide. Incorporating humming into breathing practice is a practical way to dramatically increase nasal nitric oxide levels, enhancing pulmonary function, antimicrobial defenses, and systemic vasodilation through a simple, evidence-based technique. Box breathing calms your nervous system. The autonomic nervous system operates largely outside conscious control, regulating heart rate, blood pressure, digestion, and stress response through the sympathetic, fight or flight, and parasympathetic, rest and digest, branches. Yet breathing represents a unique bridge, both automatic and voluntary, allowing conscious manipulation to influence autonomic function. Box breathing, also called square breathing or 4-square breathing, is a structured pattern where inhale, hold, exhale, and hold durations are equal, typically 4 seconds each, creating a rhythmic cycle that shifts autonomic balance toward parasympathetic dominance. This technique, used by military special operations forces, emergency responders, and athletes to manage acute stress, produces measurable changes in heart rate variability, blood pressure, and cortisol within minutes, offering a portable intervention for anxiety, pre-performance nerves, or recovery enhancement. At its core, box breathing influences autonomic balance through multiple mechanisms. The extended exhale, particularly when longer than or equal to the inhale, activates the parasympathetic nervous system through vagal stimulation. The vagus nerve, which innervates the heart and lungs, responds to prolonged exhalation by releasing acetylcholine, which slows heart rate and reduces blood pressure. The breath holds, particularly the post-inhale hold, increase carbon dioxide levels slightly, stimulating the parasympathetic response and improving CO2 tolerance. The rhythmic, predictable pattern occupies the conscious mind, reducing rumination and redirecting attention away from stressors, creating a meditative quality. The equal ratios create balance, preventing hyperventilation while maintaining adequate oxygen supply. Heart rate variability, or HRV, the variation in time between heartbeats, increases during box breathing, reflecting enhanced vagal tone and parasympathetic activity. High HRV correlates with stress resilience, emotional regulation, and cardiovascular health. Research published in Frontiers in Human Neuroscience examined Navy SEALs practicing tactical breathing, a variant of box breathing, before stressful training exercises, finding significantly lower cortisol levels and improved decision-making under pressure compared to controls. A study published in the Journal of Alternative and Complementary Medicine demonstrated that 8 weeks of daily box breathing practice, 10 minutes per session, increased HRV by 22% and reduced perceived stress scores. Research from the Medical University of South Carolina published in Psychosomatic Medicine showed that slow, rhythmic breathing at 6 breaths per minute, similar to box breathing pace, increased baroflex sensitivity, the body's ability to regulate blood pressure. A study in International Journal of Yoga found that box breathing reduced anxiety scores by 45% after a single 10-minute session in individuals with generalized anxiety disorder. Dr. Andrew Huberman, a neuroscientist at Stanford, notes that the physiological sigh, 2 quick inhales through the nose followed by extended exhale, provides faster acute stress relief, while box breathing builds sustained regulation. The practical protocol is accessible to anyone regardless of fitness level. Sit comfortably with spine straight. Eliminating restrictions on breathing, inhale through the nose for 4 seconds, filling the lungs comfortably but not maximally. Hold the breath with lungs full for 4 seconds. Without straining, exhale through the nose or mouth for 4 seconds, emptying completely but gently. Hold the breath with lungs empty for 4 seconds. This completes 1 cycle. Practice for 5 to 10 cycles, approximately 2 to 4 minutes. Beginners may start with 3-second intervals, gradually extending to 4 or 5 seconds as comfort increases. The technique can be practiced before stressful events, during breaks to reset autonomic tone, or before sleep to facilitate parasympathetic dominance. Some practitioners use visual aids, tracing a square with their eyes, 1 side per phase, to maintain rhythm. Think of box breathing as a manual override, temporarily taking control of an automatic system to recalibrate its baseline settings. Practicing box breathing is a practical way to activate parasympathetic nervous system dominance, reducing acute stress, lowering heart rate and blood pressure, and improving autonomic balance through voluntary respiratory control. The oil that broke the internet. The seed oil debate. Few nutritional topics have generated more polarized debate in recent years than seed oils, with one camp declaring them toxic inflammatory agents responsible for chronic disease, and the other dismissing concerns as alarmist pseudoscience contradicted by controlled trials. Seed oils, including soybean, corn, canola, sunflower, safflower, cottonseed, and grapeseed oils, are industrially extracted vegetable oils that became dietary staples only in the past century, now constituting approximately 20% of total caloric intake in Western diets. This represents an unprecedented shift in human fat consumption, replacing traditional fats like butter, lard, and tallow with chemically extracted oils high in omega-6 polyunsaturated fatty acids. The controversy centers not on whether these oils contain omega-6 fats, which is undisputed, but whether their consumption at modern levels drives inflammation, oxidative stress, and metabolic disease, or whether they provide cardiovascular benefits by replacing saturated fats. At its core, the seed oil debate revolves around the dramatic increase in omega-6 polyunsaturated fatty acid consumption and the industrial processing required to produce these oils. Traditional human diets, whether hunter, gatherer, agricultural, or early industrial, contained omega-6 to omega-3 ratios ranging from 1 to 1 to 4 to 1. Modern Western diets show ratios of 15 to 1 to 20 to 1. Driven primarily by seed oil consumption, omega-6 fatty acids, particularly linoleic acid, constitute 60 to 75% of most seed oils. When consumed in excess, linoleic acid becomes incorporated into cell membranes and adipose tissue, where it is highly susceptible to oxidation due to multiple double bonds in its molecular structure. This oxidation produces oxidized linoleic acid metabolites, or OXLAMs, including 4-hydroxynonenal and malondialdehyde, which are inflammatory and can damage proteins, DNA, and cellular structures. Additionally, omega-6 fats serve as precursors to inflammatory eicosanoids through the arachidonic acid pathway, including prostaglandins and leukotrienes that promote inflammation. While omega-3 fats produce anti-inflammatory mediators, the processing of seed oils involves hexane extraction, degumming, bleaching, and deodorizing at high temperatures, creating trans fats and oxidized lipids even before consumption. Research published in the BMJ analyzed dietary changes over the 20th century, documenting that linoleic acid intake increased from approximately 2 to 3% of calories in 1909 to 7 to 8% by 1999, paralleling rises in obesity, diabetes, and cardiovascular disease. A study published in Molecular Nutrition and Food Research found that high linoleic acid diets in animals increased oxidative stress markers and inflammatory cytokines. Dr. Chris Nobe, an ophthalmologist and researcher, has documented correlations between seed oil consumption and macular degeneration across populations. However, meta-analysis published in Circulation examining randomized controlled trials found that replacing saturated fats with polyunsaturated fats, including seed oils, reduced cardiovascular events by approximately 20%. Dr. Walter Willett at Harvard has argued that controlled trial evidence supports seed oil safety, while critics note that these trials often used relatively inoxidized oils and didn't account for modern ultra-processed food contexts. Research published in Nutrients by Dr. James DiMichelantonio suggests that oxidized seed oils, not fresh oils in controlled settings, drive harm. The practical approach requires distinguishing between fresh, minimally processed oils used in controlled amounts versus highly processed, repeatedly heated oils in restaurant and packaged foods. If using seed oils, purchase cold-pressed or expeller-pressed versions. Store in dark bottles away from heat and light, and use within months of opening to minimize oxidation. Avoid cooking with high polyunsaturated oils at high temperatures, which accelerates oxidation. Many seed oil critics advocate replacing them with oils higher in monounsaturated or saturated fats, including olive oil, avocado oil, coconut oil, butter, or ghee, which are more stable during cooking. The most significant exposure for most people comes not from home cooking but from restaurant foods and ultra-processed products, where oils are often reused and oxidized. Reading ingredient labels and minimizing consumption of fried foods and packaged snacks reduces oxidized lipid exposure regardless of the underlying oil debate. Think of polyunsaturated fats as perishable, fresh and protected from heat and light. They may be benign or beneficial, but oxidized through processing or cooking, they become inflammatory compounds. Minimizing consumption of industrially processed and oxidized seed oils is a practical way to reduce exposure to oxidized lipid metabolites and inflammatory compounds. While the debate continues over whether fresh, unoxidized seed oils in controlled amounts pose risk, oxidized fats are the real problem. The nutritional establishment has spent decades debating which types of dietary fat, saturated, monounsaturated, or polyunsaturated, are helpful or harmful, yet this framework may miss the more critical variable, oxidative state. A fresh, unoxidized fat, whether saturated or polyunsaturated, behaves very differently in the body than the same fat after exposure to heat, light, or oxygen has transformed its molecular structure. Oxidized fats, also called lipid peroxides or rancid fats, are found in deep-fried foods, repeatedly heated cooking oils, processed foods with extended shelf lives, and even in oils stored improperly at home. These damaged fats generate reactive compounds that drive inflammation, damage cell membranes, impair mitochondrial function, and contribute to atherosclerosis through mechanisms distinct from and more harmful than their unoxidized counterparts. The paradox is that the very processing designed to create shelf-stable, neutral-tasting oils, high heat, chemical refining, creates oxidative damage before the product reaches consumers. At its core, lipid oxidation is a chain reaction where free radicals attack the double bonds in unsaturated fatty acids, creating lipid peroxyl radicals that propagate damage to adjacent molecules. Polyunsaturated fats, with multiple double bonds, are exponentially more susceptible than monounsaturated fats with one double bond, and saturated fats with no double bonds are highly resistant. When cooking oil is heated, particularly above its smoke point, thermal energy accelerates oxidation, producing aldehydes, ketones, and cyclic compounds, including 4-hydroxynonenal, or 4-HNE, and malondialdehyde, or MDA. These reactive aldehydes bind to proteins, forming advanced lipoxidation end products, or ALES. Similar to advanced glycation end products from sugar, they modify LDL cholesterol, creating oxidized LDL or ox-LDL, which is taken up by macrophages in arterial walls, forming foam cells that initiate atherosclerotic plaques. Native, unoxidized LDL does not have this effect. which is why oxidized LDL is considered a more accurate cardiovascular risk marker than total LDL. Oxidized fats also disrupt cell membrane integrity, impairing insulin signaling, and damage mitochondrial membranes, reducing energy production. Research published in Free Radical Biology and Medicine demonstrated that repeatedly heated vegetable oils, common in commercial deep fryers, contained up to 10 times higher levels of lipid peroxidation products than fresh oils. A study published in Food Chemistry analyzed oils from restaurants, finding that oils used for frying over multiple days accumulated toxic aldehydes at levels exceeding safety recommendations. Dr. Martin Grutwald at De Montfort University published research in Food and Chemical Toxicology showing that heating sunflower and corn oil, high in polyunsaturated fats, produced aldehydes associated with cancer, heart disease, and dementia, while heating coconut oil, olive oil, and butter produced far fewer toxic compounds. A study in atherosclerosis found that oxidized linoleic acid metabolites in human adipose tissue correlated with coronary artery disease severity. Research published in the Journal of Nutritional Biochemistry showed that animals fed thermally oxidized oils developed insulin resistance and liver damage. Even when total fat and calorie intake matched controls fed fresh oils, the practical focus shifts from avoiding specific fats to preventing oxidation. Store all oils, especially polyunsaturated ones, in dark bottles, in cool environments, away from light, and use within 3 to 6 months of opening. Smell oils before use, discarding any with off or paint-like odors indicating rancidity. Avoid deep frying at home, or if necessary, use fresh oil each time and choose oxidation-resistant fats like refined avocado oil or beef tallow. Never reuse cooking oil. Restaurant fried foods represent the highest exposure, as commercial operations often reuse oil for days, accumulating oxidation products. Choose cooking methods that minimize fat oxidation, steaming, boiling, or low-temperature roasting. When sautéing, use moderate heat and stable fats. Supplement with antioxidants, including vitamin E, which protects fats from oxidation both in storage and in the body. Foods high in polyphenols, berries, green tea, dark chocolate, provide additional antioxidant protection. Think of fat oxidation like metal rust. The original material isn't necessarily toxic, but the oxidized form is corrosive and damaging. Minimizing consumption of oxidized fats through proper storage, appropriate cooking methods, and avoidance of repeatedly heated oils is a practical way to reduce inflammatory lipid metabolites that drive oxidative stress and vascular damage. The omega ratio matters. Nutritional science often examines individual nutrients in isolation, studying the effects of saturated fat, or fiber, or vitamin D as independent variables. Yet the body operates through networks where ratios and interactions often matter more than absolute amounts. The omega-6 to omega-3 fatty acid ratio exemplifies this principle. Both are essential fatty acids, required from diet because humans cannot synthesize them, and both serve critical functions. Yet they compete for the same enzymatic pathways and produce opposing effects on inflammation, blood clotting, and cellular signaling. Throughout human evolution, omega-6 and omega-3 intake remained relatively balanced, estimated at ratios between 1 to 1 and 4 to 1. Modern Western diets show ratios averaging 15 to 1 to 20 to 1, creating a pro-inflammatory state that may contribute to chronic diseases, while Mediterranean and Japanese diets maintain lower ratios, correlating with reduced cardiovascular disease and inflammatory conditions. At its core, the omega-6 to omega-3 ratio matters because these fatty acids compete for delta-6 desaturase, the enzyme that converts them into longer-chain metabolites. Omega-6 linoleic acid is converted to arachidonic acid, or AA, which produces inflammatory eicosanoids including prostaglandin E2, thromboxane A2, and leukotriene B4, compounds that promote inflammation, platelet aggregation, and vasoconstriction. Omega-3 alpha linolenic acid, or ALA, is converted to EPA and DHA, which produce anti-inflammatory mediators including resolvins and protectants that resolve inflammation and protect tissues. When omega-6 intake vastly exceeds omega-3, the shared enzymatic pathway becomes saturated with omega-6 substrates, limiting omega-3 metabolism and creating an inflammatory environment. This imbalance affects cell membrane composition, as the fatty acids incorporated into phospholipids determine membrane fluidity, receptor function, and the inflammatory mediators released when membranes are broken down. High omega-6 cell membranes release more inflammatory compounds when activated by stress, infection, or injury. Research published in Biomedicine and Pharmacotherapy reviewing evolutionary aspects of omega-6 to omega-3 ratios documented that Paleolithic diets maintained ratios near 1 to 1, while modern ratios reach 15 to 1 or higher. A study published in the American Journal of Clinical Nutrition found that reducing the omega-6 to omega-3 ratio from 15 to 1 to 4 to 1 decreased inflammatory markers, including C-reactive protein and interleukin-6, by 30 to 40%. Research from Greece published in Lipids showed that children consuming Mediterranean diets with omega-6 to omega-3 ratios of 2 to 1 had significantly lower rates of asthma and allergic conditions than those with ratios above 10 to 1. Dr. Artemis Simopoulos, a researcher who has extensively studied omega ratios, notes that Japanese populations with high fish consumption and ratios near 4 to 1 showed dramatically lower cardiovascular disease rates. A study in prostaglandins, leukotrienes and essential fatty acids demonstrated that lowering the omega-6 to omega-3 ratio improved depression scores and reduced inflammation in patients with major depressive disorder. The practical approach focuses on both reducing omega-6 and increasing omega-3 intake. Minimize seed oils, which provide concentrated omega-6, replacing them with olive oil, primarily monosaturated or saturated fats. Increase consumption of omega-3 rich foods, including fatty fish like salmon, mackerel, sardines and anchovies, targeting 2 to 3 servings weekly. Plant sources of ALA include flax seeds, chia seeds and walnuts, though conversion to EPA and DHA is inefficient, typically 5 to 10%. Omega-3 supplements, either fish oil or algae-based for vegetarians, providing 1 to 2 grams of combined EPA and DHA daily, can help correct severe imbalances. Grass-fed beef and pastured eggs contain better omega ratios than grain-fed alternatives. Think of omega-6 and omega-3 as two teams competing for resources. When one team vastly outnumbers the other, the game becomes unbalanced, and the dominant team, inflammation, controls the outcome. Optimizing the omega-6 to omega-3 ratio is a practical way to reduce chronic inflammation. Balancing pro-inflammatory and anti-inflammatory signaling pathways through dietary modification of essential fatty acid intake. Trans fats, the one oil proven harmful. The nutritional debate over dietary fats, saturated versus unsaturated, animal versus plant, has raged for decades with evolving and sometimes contradictory guidance. Yet one category of fat has achieved near universal condemnation from researchers, clinicians, and public health authorities. Trans fats, particularly artificial trans fats created through industrial hydrogenation, are the only dietary fat with no safe level of consumption and unambiguous evidence of harm. These fats, created by adding hydrogen atoms to liquid vegetable oils to make them solid and shelf-stable, dominated food manufacturing from the 1950s through early 2000s, appearing in margarine, shortening, baked goods, and fried foods. Before regulations reduced their use, trans fats constituted approximately 2 to 3% of total caloric intake in Western diets, a level associated with dramatic increases in cardiovascular disease, inflammation, and mortality. At its core, trans fat toxicity stems from its unnatural molecular configuration and its effects on cholesterol metabolism and inflammation. Natural unsaturated fats exist predominantly in the cis configuration, where hydrogen atoms on either side of the double bond are on the same side, creating a bent molecular shape. Trans fats have hydrogen atoms on opposite sides, creating a straighter structure that resembles saturated fats. This configuration allows trans fats to pack tightly, remaining solid at room temperature, but creates metabolic problems. Trans fats raise LDL cholesterol, the so-called bad cholesterol, while simultaneously lowering HDL cholesterol, the protective form, a uniquely harmful dual effect not seen with saturated or unsaturated fats. They increase lipoprotein F, or Lp(a), an independent cardiovascular risk factor, promote systemic inflammation measured by C-reactive protein and interleukin-6, and impair endothelial function, the ability of blood vessels to dilate. Trans fats also interfere with essential fatty acid metabolism, competing for the same desaturase enzymes, and incorporate into cell membranes, altering membrane fluidity and receptor function. The foundational evidence comes from the Nurses' Health Study, which followed over 80,000 women for 14 years. Research published in the New England Journal of Medicine found that each 2% increase in trans fat calories was associated with a 23% increase in coronary heart disease risk, while equivalent calories from polyunsaturated fats reduced risk by 19%. A meta-analysis published in the BMJ examining 4 prospective cohort studies with nearly 140,000 participants found that trans fat consumption increased all-cause mortality, coronary heart disease mortality, and coronary heart disease incidence. Dr. Dariush Mozaffarian, a cardiologist and nutrition researcher, estimated that eliminating artificial trans fats could prevent 10,000 to 20,000 heart attacks annually in the United States alone. Research published in Circulation showed that a 1% reduction in trans fat intake correlated with a 6% reduction in cardiovascular deaths. Based on this overwhelming evidence, the FDA determined in 2015 that partially hydrogenated oils, the primary source of artificial trans fats, are not generally recognized as safe, effectively banning them from the food supply by 2018. The practical focus involves identifying remaining sources and avoiding them completely. Check ingredient labels for partially hydrogenated oil or hydrogenated oil, which indicates trans fat presence. Current regulations allow products with less than 0.5 grams per serving to claim 0 grams, so multiple servings can still provide significant trans fats. Baked goods, microwave popcorn, frozen pizzas, and non-dairy creamers are historical sources, though reformulation has reduced content. Restaurant fried foods may still contain trans fats in some locations, particularly outside the United States. Natural trans fats, found in small amounts in dairy and ruminant meat, have a different structure, primarily vaccinic acid and conjugated linoleic acid, and have not shown the same harmful effects in research. Small amounts, less than 0.5% of calories, appear benign. Think of artificial trans fats as molecular mistakes, created for shelf stability and profit, but incompatible with human metabolism. Eliminating artificial trans fats from the diet is a practical way to remove the single most harmful category of dietary fat, reducing cardiovascular risk, inflammation, and mortality through a clear, evidence-based dietary modification. Smoke point matters. Why your oil burns. Home cooks often select cooking oils based on marketing claims, health halos, or price, while overlooking a critical physical property that determines both safety and nutritional quality. Smoke point, the temperature at which an oil begins to visibly smoke, indicating thermal breakdown. When oil reaches its smoke point, the triglyceride structure degrades, releasing free fatty acids, glycerol, and volatile compounds including acrolein, a toxic aldehyde that irritates eyes and airways. Beyond the smoke point, oils rapidly oxidize, forming the harmful lipid peroxides and inflammatory compounds discussed earlier. The visible smoke is actually aerosolized fat particles and volatile organic compounds. Creating a smoky kitchen is not merely unpleasant, it signals that you are generating oxidized, potentially carcinogenic compounds in your food. Different oils have vastly different smoke points, ranging from 225 degrees Fahrenheit for unrefined flaxseed oil to 520 degrees for refined avocado oil. Matching oil to cooking method prevents thermal damage. At its core, smoke point is determined by the oil's free fatty acid content, refining level, and degree of saturation. Free fatty acids, present in higher amounts in unrefined oils, break down at lower temperatures than intact triglycerides. This is why refined oils, which have undergone processing to remove free fatty acids, phospholipids, and other impurities, have higher smoke points than their unrefined counterparts. Extra virgin olive oil, unrefined, has a smoke point around 375 degrees Fahrenheit, while refined olive oil reaches 460 degrees. Degree of saturation also matters. Saturated fats, with no double bonds, resist oxidation and have high smoke points. Refined coconut oil at 450 degrees. Monounsaturated fats are moderately stable, while polyunsaturated fats, with multiple vulnerable double bonds, oxidize most readily and have lower smoke points. Heating any oil degrades it over time, even below the smoke point, but crossing the threshold dramatically accelerates damage. The compounds formed, particularly polycyclic aromatic hydrocarbons, or PAHs, and heterocyclic amines, or HAs, have been classified as probable carcinogens. Research published in Food Chemistry analyzed oils heated to various temperatures, finding that oils heated beyond their smoke points showed exponential increases in polar compounds, oxidation markers, and toxic aldehydes. A study published in Acta Scientific Nutritional Health compared frying performance of different oils, demonstrating that high smoke point oils like avocado and refined coconut maintain stability, while low smoke point oils like flaxseed and unrefined sesame degraded rapidly. Dr. Martin Grootveld's research at De Montfort University, published in multiple journals, showed that heating sunflower oil and corn oil, both polyunsaturated with moderate smoke points, produced aldehydes at levels 20 times higher than those considered safe by the World Health Organization when used for deep frying. A study in the Journal of Agricultural and Food Chemistry found that extra virgin olive oil, despite its moderate smoke point, showed good stability during cooking due to high polyphenol content, which provides antioxidant protection. The practical application requires matching oil to cooking temperature. For high heat cooking, searing, stir frying, and deep frying at 400 to 500 degrees Fahrenheit, use refined avocado oil, refined coconut oil, or animal fats like ghee or beef tallow. For medium heat cooking, sautéing and baking at 325 to 375 degrees. Extra virgin olive oil, unrefined coconut oil, or grass-fed butter work well. For low heat or no heat applications, dressings and finishing, use flaxseed oil, walnut oil, or extra virgin olive oil. Never reuse cooking oil, as each heating cycle lowers the effective smoke point. If oil begins smoking during cooking, discard it and start over with fresh oil at lower temperature. Install proper ventilation to remove smoke, reducing indoor air pollution. Think of smoke point as a warning light. Once it activates, you have crossed from cooking into chemical decomposition. Selecting oils with appropriate smoke points for each cooking method is a practical way to prevent thermal degradation, minimizing formation of oxidized lipids and toxic compounds that compromise both food quality and health. Cold, heat, and hormesis. Cold exposure rewires your nervous system. The instinctive response to cold is avoidance, seeking warmth and comfort through clothing, shelter, and climate control. Yet deliberate cold exposure, the practice of subjecting the body to uncomfortably low temperatures through cold water immersion, cold showers, or cryotherapy, produces adaptations that extend far beyond simple temperature tolerance. What appears to be a physical stressor, water at 50 degrees Fahrenheit immersing your body, is actually a profound neurological intervention that alters sympathetic nervous system regulation, dopamine and norepinephrine production, inflammation pathways, and even metabolic rate through activation of brown adipose tissue. The practice, common in Nordic cultures and increasingly adopted by athletes and health optimizers, demonstrates a counterintuitive principle. Voluntary exposure to acute stress can enhance resilience to chronic stress, improve mood, and recalibrate the body's stress response systems to function more efficiently. At its core, cold exposure triggers a cascade of physiological responses coordinated by the sympathetic nervous system. When cold water contacts skin, thermoreceptors send signals through afferent nerves to the hypothalamus, which activates the sympathetic response, releasing norepinephrine, also called noradrenaline, from the adrenal medulla and sympathetic nerve terminals. This catecholamine surge increases heart rate, blood pressure, and alertness while constricting peripheral blood vessels to preserve core temperature. Norepinephrine also acts as a neurotransmitter in the brain, enhancing focus, attention, and mood. Studies show that cold water immersion increases plasma norepinephrine by 200 to 500%, with levels remaining elevated for an hour or more. Dopamine, the neurotransmitter associated with motivation and reward, increases by 250% and remains elevated even longer, potentially explaining the mood enhancement and sense of accomplishment reported after cold exposure. Cold also activates brown adipose tissue, or BAT, a metabolically active fat that generates heat through uncoupling protein 1, or UCP1, burning calories without shivering. Regular cold exposure increases BAT volume and activity, improving metabolic flexibility and glucose disposal. Research published in PLOS 1 examined individuals practicing daily cold water swimming, finding significant reductions in inflammatory markers including interleukin-6 and increases in anti-inflammatory cytokines. A landmark study published in European Journal of Applied Physiology demonstrated that regular cold water immersion over 6 weeks increased metabolic rate by approximately 300 calories per day through BAT activation. Dr. Susanne Berg, a researcher from the University of Copenhagen, published work in Cell Reports Medicine showing that individuals who practiced winter swimming had higher BAT activity and improved insulin sensitivity. Research from the Netherlands, published in Psychosomatic Medicine, examined 3,000 participants who took cold showers for 30 days, finding a 29% reduction in sickness absence from work compared to controls. Dr. Andrew Huberman, a neuroscientist at Stanford, emphasizes that the sustained dopamine elevation from cold exposure, unlike the spike and crash from stimulants, provides stable motivation enhancement. A study in medical hypotheses proposed that cold exposure acts as a mild electroshock therapy, sending electrical impulses from peripheral nerves to the brain that have antidepressant effects. The practical protocol involves gradual adaptation rather than extreme initial exposure. Begin with 30 seconds of cold water at the end of a warm shower, focusing on controlled breathing rather than gasping. Increase duration by 15 to 30 seconds weekly, working toward 2 to 3 minutes. Water temperature between 50 and 60 degrees Fahrenheit provides sufficient stimulus. Full immersion in cold baths or natural water amplifies effects but requires greater caution. Never practice alone. The optimal timing appears to be 11 minutes total per week, divided across multiple sessions. Based on Dr. Sperg's research, some practitioners prefer morning exposure for alertness, while others use it post-workout for recovery. Though cold immediately after resistance training may blunt hypertrophy adaptations, the key is maintaining calm breathing, long exhales through pursed lips, rather than hyperventilating, which trains vagal tone and stress resilience. Exit before shivering becomes uncontrollable. Think of cold exposure as a controllable stressor, a safe environment to practice maintaining calm during physiological panic, training that transfers to psychological stressors. Practicing deliberate cold exposure is a practical way to enhance sympathetic nervous system regulation, increase sustained dopamine and norepinephrine production, activate metabolic brown fat, and build stress resilience through controlled physiological challenge. Sauna use extends lifespan. Heat exposure through sauna bathing is often dismissed as mere relaxation or luxury, a pleasant experience with temporary benefits but little long-term health significance. Yet data from large prospective cohort studies reveals something remarkable. Regular sauna use, particularly frequent sessions at high temperatures, correlates with dramatic reductions in all-cause mortality, cardiovascular death, Alzheimer's disease, and other chronic conditions, with magnitude of benefit rivaling or exceeding many pharmaceutical interventions. Finnish populations, where sauna culture is deeply embedded and nearly every household has access, provide the most extensive data, showing that individuals using saunas 4 to 7 times weekly have approximately 40% lower all-cause mortality compared to once-weekly users. This is not correlation obscured by confounding dose-response relationships, and mechanistic studies reveal specific biological pathways through which heat stress, like cold stress, activates protective adaptations. At its core, sauna use induces hypothermic conditioning, a state where elevated core body temperature triggers heat shock protein production, cardiovascular adaptations, and metabolic changes. When core temperature rises to approximately 102 degrees Fahrenheit, cells throughout the body increase production of heat shock proteins, or HSPS, molecular chaperones that refold damaged proteins, prevent aggregation, and target irreparably damaged proteins for degradation. This process, called proteostasis, declines with age, and restoring it through heat exposure may slow cellular aging. Sauna use also mimics moderate cardiovascular exercise. Heart rate increases to 100 to 150 beats per minute. Cardiac output rises, and blood vessels dilate, improving endothelial function. Studies show that a single sauna session can lower blood pressure by 10 to 20 millimeters of mercury, lasting several hours. Growth hormone secretion increases dramatically during sauna use, potentially 2 to 5-fold, supporting tissue repair and metabolism. Sauna exposure increases BDNF, or brain-derived neurotrophic factor, a protein critical for neuronal health and neuroplasticity. The foundational research comes from the Kuopio Ischemic Heart Disease Risk Factor Study, a prospective cohort following over 2,000 Finnish men for more than 20 years. Results published in JAMA Internal Medicine showed that men using saunas 2 to 3 times weekly had a 27% lower cardiovascular mortality rate, while those using saunas 4 to 7 times weekly showed a 50% reduction compared to once-weekly use. A follow-up study published in Age and Aging found that frequent sauna use reduced Alzheimer's disease and dementia risk by 65%. Research published in American Journal of Physiology demonstrated that regular sauna bathing improved arterial compliance, a measure of blood vessel flexibility, by approximately 43%. Dr. Jari Lokkanen, lead researcher on the Finnish studies, documented that longer session duration, over 19 minutes, provided greater benefit than shorter sessions. A study published in the Journal of Human Hypertension showed that sauna use reduced systolic blood pressure and improved endothelial function comparably to moderate intensity exercise. The practical protocol involves sessions at 170 to 190 degrees Fahrenheit, typical for Finnish dry saunas, for 15 to 20 minutes, repeated 2 to 7 times weekly. Begin conservatively, 8 to 10 minutes at lower temperatures, building tolerance over weeks. Proper hydration is essential. Drink 16 to 24 ounces of water before and after sessions, with electrolytes if sweating heavily. Exit if you feel dizzy, nauseated, or experience headache. Cool down gradually, allowing heart rate to normalize. Some practitioners alternate between sauna and cold plunge for contrast therapy, though this requires additional caution. Infrared saunas, operating at lower air temperatures but penetrating heat through infrared radiation, provide similar benefits with potentially better tolerability for heat-sensitive individuals. Though research is less extensive, contraindications include pregnancy, recent heart attack, unstable angina, and certain medications. Consult a physician if any cardiovascular conditions exist. Think of sauna use as hormetic stress for longevity, temporary controlled elevation of core temperature that signals the body to strengthen its protective systems. Regular sauna use is a practical way to activate heat shock proteins, improve cardiovascular function, enhance neurological health, and reduce mortality risk through consistent thermal stress that triggers beneficial adaptations. Hormesis is the pattern. Modern culture operates on an implicit assumption that optimal health requires minimizing all stressors, avoiding discomfort, maintaining constant comfort, and eliminating anything that challenges homeostasis. This framework, while appealing, contradicts a fundamental biological principle, hormesis, the phenomenon where low doses of stressors that would be harmful at high doses actually trigger beneficial adaptations. The pattern appears across temperature extremes, exercise, fasting, phytochemicals in plants, and even radiation. A moderate dose of stress activates cellular defense mechanisms, including antioxidant production, DNA repair, protein quality control, and mitochondrial biogenesis, that not only neutralize the immediate stressor but leave the organism more resilient to future challenges. The dose-response relationship follows a U-shaped or J-shaped curve. Too little stimulus provides no benefit. Moderate stimulus triggers adaptation, and excessive stimulus causes damage. Understanding hormesis explains why eliminating all stress, through sedentary comfort, climate control, and constant food availability, may paradoxically increase disease risk. At its core, hormesis operates through cellular stress response pathways that evolve to handle periodic challenges. Heat shock activates heat shock factor 1, or ACE-F1, which increases heat shock protein production. These proteins protect all cellular proteins, not just during heat stress, providing ongoing quality control. Cold exposure activates cold shock proteins and PGC1-alpha, a master regulator of mitochondrial biogenesis. Exercise creates mechanical stress, depletes energy stores, and produces reactive oxygen species, triggering adaptations including increased mitochondrial density, enhanced antioxidant enzyme production, particularly superoxide dismutase and catalase, and improved insulin sensitivity. Fasting activates AMPK and sirtuins, promoting autophagy and metabolic efficiency. Phytochemicals, compounds plants produce as pesticides against insects and pathogens, including sulforaphane from broccoli and resveratrol from grapes, activate the NRF2 pathway, increasing endogenous antioxidant production. The key insight is that cells don't just neutralize the stressor, they overcompensate, leaving protective systems elevated after the stress resolves. Research published in Dose Response reviewed hundreds of studies documenting hormetic responses across biological systems, finding that low-dose stressors consistently produced J-shaped dose-response curves. A landmark paper in Free Radical Biology and Medicine by Michael Risto demonstrated that the health benefits of exercise result from transient increases in oxidative stress, not from direct antioxidant effects, and that supplementing with high-dose synthetic antioxidants can actually block exercise adaptations by preventing the hormetic signal. Research published in Cell Metabolism showed that intermittent fasting produced greater health benefits than continuous caloric restriction at the same total calorie deficit. Attributed to repeated activation of stress response pathways, Walter Longo's work on fasting mimicking diets, published in Science Translational Medicine, demonstrated that periodic nutritional stress activated cellular regeneration. A study in Aging Research Reviews examined centenarian populations, finding common patterns of intermittent stress exposure, physical labor, periodic food scarcity, temperature fluctuations, absent in modern sedentary populations. The practical application involves intentionally incorporating moderate, controllable stressors, cold exposure for 2 to 3 minutes, sauna sessions for 15 to 20 minutes, high-intensity interval training once or twice weekly, time-restricted eating creating daily 12 to 16-hour fasts, and consumption of phytochemical-rich plants, particularly cruciferous vegetables. The critical variables are dose, sufficient to trigger response but not overwhelm, and recovery, allowing adaptation to occur. Daily chronic stress without recovery, as in overtraining or chronic caloric restriction, produces opposite effects, depleting rather than building resilience. The pattern should be intermittent, periods of challenge alternating with recovery. Think of Hormesis as a vaccine for cellular stress. Controlled exposure to manageable threats trains your cells to respond more effectively to all challenges. Embracing hormetic stressors is a practical way to activate cellular defense and repair mechanisms, building resilience through strategic exposure to cold, heat, exercise, and nutritional challenges that strengthen rather than weaken biological systems. Contrast therapy, the Scandinavian secret. Scandinavian countries, particularly Finland, Norway, and Sweden, consistently rank among the world's healthiest and happiest populations, and while many factors contribute, one distinctive cultural practice stands out: contrast therapy, the alternating exposure to extreme heat and extreme cold, typically rotating between sauna and cold water plunge. This practice, which might seem like physiological whiplash, creates unique adaptations beyond those achieved by heat or cold alone. The rapid alternation forces cardiovascular, nervous, and endocrine systems to shift between opposing states: sympathetic activation from cold, parasympathetic from heat, vasoconstriction then vasodilation, creating a training effect for autonomic regulation. Athletes increasingly adopt contrast therapy for recovery, while longevity enthusiasts use it for the combined benefits of both temperature extremes. Compressed into shorter total time, at its core, contrast therapy creates rapid oscillation between thermoregulatory demands. Sauna exposure at 170 to 190 degrees Fahrenheit causes peripheral vasodilation. Blood vessels in skin and extremities expand dramatically to dissipate heat, increasing blood flow to the periphery while core temperature rises, heart rate increases, mimicking cardiovascular exercise. When you transition immediately to cold water at 40 to 60 degrees Fahrenheit, the body experiences intense vasoconstriction. Peripheral blood vessels constrict rapidly, shunting blood back to the core to preserve vital organ temperature. This vascular exercise, repeated over multiple cycles, improves endothelial function, the ability of blood vessels to dilate and constrict efficiently. The dramatic shifts in blood flow may enhance waste removal from tissues and delivery of oxygen and nutrients. The autonomic nervous system, forced to rapidly switch between sympathetic dominance, cold, and parasympathetic activation, heat becomes more flexible and responsive. Contrast exposure also produces a unique neurochemical response, combining the sustained dopamine elevation from cold with the endorphin release and relaxation from heat. Research published in Scandinavian Journal of Medicine and Science in Sports examined contrast water therapy, alternating hot and cold water immersion, in athletes, finding reduced muscle soreness and faster perceived recovery compared to passive rest, though performance effects were mixed. A study published in the Journal of Strength and Conditioning Research showed that contrast therapy reduced inflammatory markers, including creatine kinase and C-reactive protein more effectively than either temperature extreme alone. Research from the University of Portsmouth, published in European Journal of Applied Physiology, demonstrated that contrast therapy improved arterial stiffness, a measure of vascular health, by approximately 15% after 4 weeks of regular practice. Dr. Susanne Søberg's research in Denmark, published in Cell Reports Medicine, documented that winter swimmers who practiced sauna followed by cold water exposure showed superior metabolic adaptations, including increased brown fat activity, compared to those practicing only one temperature extreme. A study in International Journal of Circumpolar Health examining Finnish populations found strong correlations between regular sauna and winter swimming practice and reduced respiratory infections. The practical protocol involves 3 to 5 cycles of heat and cold. Spend 10 to 15 minutes in sauna at 170 to 190 degrees, followed by 1 to 3 minutes in cold water or cold shower at 50 to 60 degrees. Repeat the cycle, ending with cold for invigoration or heat for relaxation depending on timing and preference. Begin with shorter durations and fewer cycles, building tolerance progressively. Hydration is critical, as the combination significantly increases fluid loss through sweating and diuresis. Drink water between cycles. The practice is best done 2 to 4 times weekly rather than daily, allowing recovery. Contraindications include cardiovascular disease, pregnancy, and uncontrolled hypertension, due to the dramatic blood pressure and heart rate fluctuations. Some practitioners prefer cold then heat, which may better support sleep if practiced in evening. While heat then cold provides alertness, think of contrast therapy as interval training for your vascular and nervous systems, forcing rapid adaptation that builds capacity for both extremes. Implementing contrast therapy is a practical way to combine the benefits of heat and cold exposure while training cardiovascular and autonomic flexibility through rapid alternation between opposing physiological states. Cold showers and immune function. The claim that cold showers prevent illness circulates widely, often supported by anecdote and traditional practice, but questioned by conventional medicine as lacking rigorous evidence. Yet a landmark randomized controlled trial, the largest of its kind, examining over 3,000 participants, provided clear data. Individuals who ended daily showers with 30 to 90 seconds of cold water experienced a 29% reduction in sickness absence from work compared to controls taking warm showers exclusively. This finding, published in a peer-reviewed journal, suggests that cold exposure influences immune function through measurable mechanisms, though the reduction was in perceived illness and work absence, not objective infection rates. The question is whether this represents true immune enhancement, psychological resilience that allows working through minor illness, or a combination, and what mechanisms might explain the effect. At its core, cold exposure influences immune function through multiple pathways involving the sympathetic nervous system, stress hormones, and white blood cell activity. Cold water immersion triggers massive norepinephrine release, increasing plasma levels by 200 to 500% as documented earlier. Norepinephrine, beyond its role in alertness and mood, modulates immune cell activity. Acute norepinephrine elevation mobilizes lymphocytes, natural killer cells, and other immune cells from tissues and lymph nodes into circulation, temporarily increasing white blood cell counts. This may prime the immune system for rapid response. Cold exposure also activates the sympathetic nervous system's anti-inflammatory pathways, releasing cortisol, which, while immunosuppressive at chronic high levels, at acute moderate levels helps regulate inflammation and prevents excessive immune activation. Some researchers propose that regular cold exposure creates a form of immune conditioning, repeated mild stress that keeps immune surveillance active rather than dormant. Additionally, cold may influence the vagus nerve, which has recently been recognized as modulating immune function through the cholinergic anti-inflammatory pathway. The landmark study was published in PLOS One by researchers at the Academic Medical Center in Amsterdam. 3,078 participants were randomized to hot to cold showers, 30, 60, or 90 seconds of cold, versus control hot showers for 30 consecutive days. The cold groups, all 3 durations, showed a combined 29% reduction in self-reported sickness absence, though no difference in illness duration or severity when sick. Notably, 64% of cold shower participants continued the practice after the trial ended, suggesting perceived benefit. Research published in Immunology Letters showed that cold water immersion increased circulating concentrations of white blood cells, particularly lymphocytes and monocytes. A study in brain behavior, and immunity demonstrated that cold exposure in animals enhanced natural killer cell activity, a critical component of antiviral and anticancer immunity. Dr. Geert Biers, lead researcher on the Dutch cold shower study, noted that the mechanism likely involves both physiological immune changes and psychological factors, including increased stress resilience. Research from the University of Virginia, published in Medical Hypotheses, proposed that cold exposure activates the sympathetic nervous system in ways that may enhance immune surveillance. The practical application is straightforward and requires no special equipment. At the end of your normal warm shower, gradually turn the water to cold, aiming for 60 degrees or as cold as available. Begin with 30 seconds, focusing on controlled breathing, long exhales, rather than gasping. Work up to 60 to 90 seconds over several weeks. The key is consistency. Daily practice appears more important than duration. No additional benefit was found for 90 seconds versus 30 in the Dutch study. Morning application provides alertness benefits. While some prefer evening to practice stress management before sleep, though cold can be stimulating, the practice is safe for most individuals, though those with cardiovascular conditions should consult physicians due to the acute blood pressure and heart rate elevation. Think of cold showers as a daily immune system check-in, a brief signal that keeps surveillance active and stress response calibrated. Daily cold shower practice is a practical way to potentially enhance immune function and reduce illness-related work absence. Using brief cold exposure to influence white blood cell activity, sympathetic nervous system regulation, and stress resilience. Light as medicine. Light controls your master clock, circadian rhythm. Every cell in your body operates on an approximately 24-hour cycle, yet most people treat light exposure as an aesthetic or convenience issue rather than a primary determinant of metabolic health, sleep quality, and hormonal regulation. Light is the most powerful external signal for synchronizing your circadian rhythm, the internal biological clock generated by the suprachiasmatic nucleus in the hypothalamus that coordinates timing of sleep, hormone release, body temperature, and metabolism across every organ system. The modern environment, characterized by indoor lighting, screen exposure at night, and minimal bright light during day, creates chronic circadian disruption that manifests as insomnia, metabolic dysfunction, mood disorders, and increased disease risk. The solution is not eliminating artificial light, which is impractical, but understanding the specific wavelengths, intensities, and timing that entrain or disrupt your master clock. At its core, circadian rhythm entrainment occurs through specialized photoreceptors in the retina called intrinsically photosensitive retinal ganglion cells, or iPRGCs, which contain melanopsin, a photopigment most sensitive to blue light wavelengths between 450 and 480 nanometers. These cells, distinct from rods and cones used for vision, project directly to the suprachiasmatic nucleus, or SCN. When blue light hits melanopsin in the morning, the SCN suppresses melatonin production from the pineal gland, promotes cortisol release, and resets the circadian clock to the start of the biological day. This signal coordinates peripheral clocks in organs throughout the body, synchronizing metabolism. In the absence of light, particularly blue wavelengths, melatonin production increases, typically beginning 2 to 3 hours before habitual bedtime, creating the biological signal for sleep. The critical variables are timing, intensity measured in lux, and spectral composition. Morning bright light exposure, ideally within 1 hour of waking, advances the circadian phase, making you sleepier earlier, while evening bright light delays it, shifting sleep later. Research published in the Journal of Clinical Investigation demonstrated that individuals exposed to dim indoor lighting, approximately 200 lux, throughout the day showed reduced circadian amplitude, less distinct day-night differences, compared to those receiving bright outdoor light, 10,000 lux or higher, during morning hours. A landmark study published in Current Biology examined campers exposed only to natural light for 1 week, finding their circadian rhythm synchronized perfectly to the solar day, with melatonin onset occurring near sunset, approximately 2 hours earlier than their indoor baseline. Dr. Seema Hatta at the National Institutes of Health, who discovered iPRGCs, documented that these cells respond to cumulative light exposure, requiring sufficient duration and intensity. Research published in Sleep showed that morning bright light exposure, 10,000 lux for 30 minutes, significantly improved sleep quality and mood in individuals with delayed sleep phase syndrome. The practical protocol prioritizes morning light exposure and evening light restriction. Within 30 to 60 minutes of waking, get outside for 10 to 30 minutes, or position yourself near a window. Even overcast outdoor light provides 1,000 to 10,000 lux, far exceeding indoor lighting at 50 to 300 lux. If outdoor access is impossible, light therapy boxes providing 10,000 lux at a distance of 12 to 18 inches replicate the effect. In the evening, 2 to 3 hours before bed, dim indoor lights. Use warm-toned bulbs under 2700 Kelvin and minimize screen exposure or use blue blocking glasses. Think of light as a Zeitgeber, German for time giver, the external signal that keeps your internal clock synchronized to the external world. Optimizing light exposure timing and intensity is a practical way to synchronize circadian rhythms, improving sleep quality, metabolic function, and mood through strategic use of bright morning light and dim evening environments. Red light therapy actually works. Red and near-infrared light therapy sounds like the pseudoscientific territory of wellness influencers selling expensive LED panels. Yet this intervention has unexpectedly robust scientific support, including FDA clearance for specific medical applications and hundreds of peer-reviewed studies documenting effects on cellular energy production, wound healing, inflammation, and tissue repair. The mechanism, photobiomodulation, involves specific wavelengths of red light between 650 and 850 nanometers, penetrating skin and tissue to interact with mitochondria, increasing ATP production through enhanced cytochrome C oxidase activity in the electron transport chain. What distinguishes this from light's circadian effects is the target, not the brain's circadian system but cellular mitochondria throughout the body, and the wavelengths, red and near-infrared rather than blue, creating therapeutic applications ranging from skin health to muscle recovery to potentially neuroprotection. At its core, photobiomodulation works through absorption of photons by chromophores, light-sensitive molecules, in cells, particularly cytochrome C oxidase, complex 4 in the mitochondrial electron transport chain, nitric oxide, which can inhibit cytochrome C oxidase under certain conditions, is displaced by red and near-infrared photons, enhancing electron transport and increasing ATP production. This energy boost allows cells to function more efficiently, supporting repair, regeneration, and inflammation resolution. Red light also stimulates release of nitric oxide from hemoglobin and other storage sites, improving local blood flow. Additionally, photobiomodulation modulates reactive oxygen species, or RS, at low doses. Red light reduces excessive ROS, acting as an antioxidant, while at moderate doses, it creates mild ROS increases that trigger beneficial hormetic responses, including activation of transcription factors like NF, kappa B, and NRF2 that regulate inflammation and antioxidant production. Research published in Photomedicine and Laser Surgery demonstrated that red light therapy at 630 to 880 nanometers improved wound healing rates by approximately 40% compared to controls, attributed to enhanced fibroblast activity and collagen synthesis. A study published in the Journal of Investigative Dermatology showed that red light treatment increased collagen density and reduced wrinkles in photoaged skin, leading to FDA clearance for aesthetic applications. Research from the Wellman Center for Photomedicine at Harvard, published in PLOS One, demonstrated that near-infrared light therapy reduced delayed onset muscle soreness and accelerated recovery after eccentric exercise. A study in Lasers in Surgery and Medicine found that photobiomodulation reduced inflammatory markers and pain in patients with knee osteoarthritis. Dr. Michael Hamblin, formerly at Harvard Medical School and a leading photobiomodulation researcher, has published extensively documenting effects on neurological conditions, with animal studies showing improved outcomes in traumatic brain injury and neurodegenerative disease models. The practical application requires understanding dosimetry, wavelength, power density, and treatment duration. Effective wavelengths are 650 to 850 nanometers, with 660 and 850 being most common. Power density, measured in milliwatts per square centimeter, should be 5 to 200. Too low provides insufficient energy. Too high can cause heat damage. Treatment time ranges from 5 to 20 minutes, depending on power and target depth. Devices range from small handheld units for targeted treatment to full body panels. Position light 6 to 12 inches from skin for panels, closer for lower power devices. Daily or every other day treatment appears optimal for most applications. No eye protection is needed for red light, though near-infrared should not be aimed directly at eyes. Think of red light as mitochondrial charging, temporarily boosting cellular energy production to accelerate repair and reduce inflammation. Red light therapy is a practical way to enhance mitochondrial function and cellular energy production, supporting tissue repair, reducing inflammation, and potentially improving recovery through wavelength-specific photobiomodulation. Blue light timing is everything. Blue light has been demonized as inherently harmful, spawning an industry of blue-blocking glasses, screen filters, and devices marketed as protection against digital damage. Yet this framing fundamentally misunderstands how light wavelengths affect human biology. Blue light, wavelengths between 450 and 490 nanometers, is not categorically good or bad. Its effects depend entirely on timing, intensity, and context. Morning and daytime blue light exposure is essential, suppressing melatonin, enhancing alertness, entraining circadian rhythm, and improving mood. Evening and nighttime blue light exposure creates problems, suppressing melatonin when it should be rising, delaying sleep onset, and fragmenting sleep architecture. The solution is not eliminating blue light, which would disrupt daytime function, but restricting it to appropriate times, recognizing that our ancestors received intense blue, rich sunlight for 12 to 14 hours daily, followed by complete darkness or firelight containing minimal blue wavelengths. At its core, blue light's circadian effects operate through melanopsin, containing intrinsically photosensitive retinal ganglion cells that project to the suprachiasmatic nucleus. As discussed in the first segment, these cells are most sensitive to blue wavelengths, requiring approximately 100 times less blue light than red light to trigger the same circadian response. Melatonin suppression is particularly sensitive. Exposure to as little as 30 to 50 lux of blue light, equivalent to many smartphone screens, can suppress melatonin by approximately 50%. This matters because melatonin is not merely a sleep-inducing hormone. It regulates numerous physiological processes, including antioxidant activity, immune function, and glucose metabolism. Chronic melatonin suppression through evening light exposure correlates with increased risk of metabolic syndrome, cancer, particularly breast and prostate, and mood disorders. The effect is dose-dependent. Brighter light and longer duration create greater suppression, and timing-dependent. Evening exposure is most disruptive while morning exposure is beneficial. Research published in the Journal of Clinical Endocrinology and Metabolism demonstrated that 2 hours of tablet screen exposure before bed, emitting blue-rich light, suppressed melatonin by approximately 23% and delayed melatonin onset by 90 minutes. A study published in Proceedings of the National Academy of Sciences compared reading on light-emitting devices versus printed books, finding that e-reader users took longer to fall asleep, had reduced evening sleepiness, reduced melatonin secretion, delayed circadian timing, and reduced next morning alertness. Dr. Charles Chesler at Harvard Medical School has documented that the introduction of electric lighting, particularly blue-rich LEDs, has shifted average sleep timing later by approximately 2 hours compared to pre-industrial populations. Research published in Sleep Medicine Reviews found that blue-blocking glasses worn for 2 to 3 hours before bedtime significantly improved sleep quality and duration in individuals exposed to screens. The practical approach embraces blue light during appropriate times and restricts it in evening. Maximize bright light exposure, which includes blue wavelengths, in the first half of the day, enhancing alertness and circadian entrainment. After sunset, or 2 to 3 hours before bedtime, reduce blue light exposure by dimming lights, using warm temperature bulbs, 2000 to 2700 Kelvin, which emit minimal blue, or wearing blue blocking glasses. These glasses, filtering wavelengths below 500 nanometers, allow evening screen use without melatonin suppression. Many devices now offer night mode or blue light filters, though effectiveness varies. Some individuals use red, tinted bulbs in bedside lamps, providing visibility without circadian disruption. Think of blue light as a biological signal. In morning and day, it signals wakefulness and activity. In evening, It creates confusing signals that disrupt the transition to sleep, timing blue light exposure to morning and daytime hours, while restricting it in evening is a practical way to support natural melatonin rhythms and circadian alignment, enhancing both daytime alertness and nighttime sleep quality. Shift work destroys circadian rhythm. Approximately 15 to 20% of the workforce in industrialized nations works non-traditional schedules, including night shifts, rotating shifts, or extended irregular hours that require wakefulness when circadian biology signals sleep. This is not merely inconvenient, it creates a profound conflict between external demands and internal biological timing. Shift work disorder, recognized in medical literature, affects approximately 10 to 40% of shift workers, characterized by insomnia during designated sleep times, excessive sleepiness during work hours, and chronic circadian misalignment. Even beyond this clinical threshold, shift work increases risk of cardiovascular disease by 40%, metabolic syndrome by approximately 57%, certain cancers, particularly breast cancer, and all-cause mortality. The International Agency for Research on Cancer has classified night shift work as a probable carcinogen, based on disruption of circadian rhythm and melatonin suppression. For the millions working these schedules out of necessity, understanding the mechanisms of harm and potential mitigation strategies becomes critical. At its core, shift work creates circadian misalignment, the desynchronization between internal biological timing and external behavior. When you work nights, your circadian clock, still entrained to daytime light exposure, signals that you should be asleep. Melatonin levels rise, core body temperature drops, and metabolic processes shift to fasting mode, all while you are demanding wakefulness, alertness, and food processing. This mismatch impairs cognitive performance, increases accident risk, and creates metabolic dysfunction. The suprachiasmatic nucleus attempts to adjust to the new schedule, but entrainment is slow, requiring approximately 1 day per hour of time zone change, meaning a complete 12-hour shift might require nearly 2 weeks. Most shift workers never fully adapt because days off, social obligations, and daylight exposure pull the clock back toward normal timing, creating perpetual jet lag. Chronic melatonin suppression during night work hours removes its protective effects, including antioxidant activity and tumor suppression, while eating during circadian night, when insulin sensitivity is lowest, promotes glucose intolerance and weight gain. Research published in the New England Journal of Medicine reviewed multiple cohort studies, finding that long-term rotating night shift work, over 5 years, increased cardiovascular disease risk by approximately 40%, even after adjusting for other risk factors. A study published in Diabetes Care demonstrated that shift workers had 65% higher rates of type 2 diabetes, attributed to circadian disruption of glucose metabolism. Research from the Harvard Nurses' Health Study, published in PLOS Medicine, found that women working rotating night shifts for more than 5 years had a moderately increased risk of breast cancer. A study published in Sleep using forced desynchrony protocols showed that eating during circadian night reduced leptin, the satiety hormone, and increased glucose and insulin responses to identical meals. Dr. Frank Shear at Harvard has documented that circadian misalignment, even in laboratory settings over just 10 days, produced prediabetic glucose responses in healthy individuals. The practical mitigation strategies cannot eliminate risk but may reduce it. If possible, maintain consistent shift timing rather than rotating schedules, allowing partial circadian adaptation. Use bright light, 5,000 to 10,000 lux, during work hours to suppress melatonin and enhance alertness. On commute home, wear dark sunglasses to prevent morning light from resetting your clock. Sleep in completely dark rooms with blackout curtains and consider eye masks. Scheduled napping, 20 to 30 minutes before shifts, can improve alertness. Avoid eating during night hours when possible, or minimize carbohydrate intake which requires higher insulin response. Consider melatonin supplementation, 0.5 to 3 milligrams, before daytime sleep to facilitate sleep initiation. Monitor metabolic markers, glucose, lipids, blood pressure, more frequently. Think of shift work as chronic biological jet lag, constantly asking your body to function at times evolution did not prepare for. Understanding shift work's circadian disruption is a practical way to implement mitigation strategies, though complete adaptation is unlikely. and recognizing health risks allows enhanced monitoring and informed occupational decisions. Seasonal affective disorder and light therapy. Winter brings predictable changes, shorter days, colder temperatures, and for approximately 5 to 10% of people in northern latitudes, a recurrent major depressive episode that resolves in spring. This pattern, called seasonal affective disorder, or SAD, is not merely the winter blues or preference for warm weather. It is a clinically recognized subtype of major depressive disorder characterized by hypersomnia, increased appetite, carbohydrate craving, weight gain, and profound low mood. The timing corresponds precisely to reduced daylight exposure, with prevalence increasing at higher latitudes where winter days become dramatically shorter. Rates in Florida are approximately 1%, while in Alaska they reach 10%. What makes SAD particularly interesting is that it responds to a non-pharmaceutical intervention with effect sizes comparable to antidepressant medications. Bright light therapy, providing strong evidence that light deficiency, not just circadian timing, affects mood and neurochemistry. At its core, seasonal affective disorder likely results from reduced light exposure affecting multiple systems, including circadian rhythm, neurotransmitter production, and possibly vitamin D status. Reduced daylight, particularly the low solar angle providing less intense light, decreases the signal to the suprachiasmatic nucleus, potentially causing circadian phase delay, where the biological clock runs later than the solar day. This creates a mismatch, waking while melatonin is still elevated, contributing to morning grogginess and hypersomnia. Serotonin, the neurotransmitter targeted by SRI antidepressants, shows seasonal variation, with production lowest in winter, partly due to reduced light exposure. Light stimulates serotonin synthesis in the brain, and retinal light exposure specifically increases serotonin in regions involved in mood regulation. The pineal gland produces more melatonin during longer nights, and individuals with SAD may have altered melatonin metabolism, creating excessive daytime sleepiness. Some researchers propose that reduced vitamin D, synthesized through sun exposure, contributes. Though supplementation studies show mixed results, research published in the American Journal of Psychiatry conducted a meta-analysis of randomized controlled trials, finding that bright light therapy, 10,000 lux for 30 minutes daily, produced response rates, 50% or greater symptom reduction of approximately 67% in SAD, comparable to antidepressant medications. A study published in JAMA Psychiatry compared light therapy, fluoxetine, and SRI combination, and placebo in SAD patients. Light therapy alone showed equal efficacy to medication, with faster onset of action within 1 to 2 weeks. Dr. Norman Rosenthal, who first described SAD in the 1980s, documented that light therapy works best when administered in early morning, 6 to 8 a.m., supporting the circadian phase advance hypothesis. Research published in Journal of Affective Disorders showed that light therapy increased serotonin levels and reduced depressive symptoms in parallel. A study in depression and anxiety found that light therapy prevented SAD recurrence when started in early fall, before symptom onset. The practical protocol involves bright light therapy boxes, certified to provide 10,000 lux at a specified distance, typically 12 to 18 inches. Position the light box at eye level or slightly above, at an angle, not staring directly at it. Use for 20 to 30 minutes, ideally within 30 to 60 minutes of waking. Timing matters. Morning use is most effective, while evening use may worsen sleep. Most individuals notice improvement within 1 to 2 weeks, with full effects by 4 weeks. Side effects are minimal. Occasional headache, eye strain, or mild agitation, typically resolving with shorter duration or increased distance. Light therapy is contraindicated in bipolar disorder without medical supervision, as it may trigger mania. Combining light therapy with dawn simulation, gradually increasing bedroom light before waking, enhances effects. Think of SAD as light deficiency disorder, where northern winters fail to provide the photon dose required for optimal neurochemistry. Bright light therapy is a practical way to treat seasonal affective disorder, providing photon exposure sufficient to advance circadian phase, increase serotonin production, and alleviate depressive symptoms through a well-tolerated, evidence-based intervention.